KFUG Community Radio, Paul Kritz on this end. It is time now for Health Matters with Lynn Szabo, PA at large in our community. Lynn, how you doing today?
I'm doing great.
All right, so we have reached the point in the COVID broadcasts, and I know we've talked about this topic before, but now it's like, I guess it's just real for me personally because it's time for me to think about this.
Yeah, it's more real.
COVID booster shots. What's up?
So let me tell you where we are in the process. So remember that the FDA puts recommendations out to the CDC, who passes them, agrees with them, then passes them along to the CDC director, and then they become official.
Okay.
So this is the FDA's word and a little bit of the science behind it. Okay.
Alrighty.
So that's where we're at with that. But in reality, we've been putting a lot of shots in arms for people who wanted them.
As booster shots, right?
As booster shots, yeah. So for Pfizer and Moderna recipients, boosters are recommended after 6 months for those who are 65 and older, those who are 18 to 64 years old with comorbidities, or those who are frequently exposed. And that's actually, frequently exposed is kind of, there's like really specific recommendations here, and then they kind of sum it up with like something that could be widely interpreted in a lot of different ways and kind of wide open.
The kind of amorphous phrase of frequently exposed.
So
right?
I see a struggle between the rule insisters and the rule deniers.
Okay.
So anyway,
but they're talking about you, right? I mean, healthcare people who
yeah.
Which part of me? I mean the folks who are. Who come in contact with sick people all the time, who are frequently exposed. I would assume that's what they're talking about, right?
Yeah, but that's hierarchical way of looking at it. But they're, how about people who are home health aides? Who are the mothers, who almost always female, of kids in school.
Yeah.
So, they not only have a lot of exposure, but they also they're working with a population that's vulnerable.
Mm-hmm,
so, I mean, they're looking at a lot of different people that are kind of outside what you'd standardly think of as healthcare provider.
Okay.
Perhaps also people who are in and out of homeless encampments.
Completely in and out of homeless encampments, in and out of county jail. Who are maybe couch surfing and one place one night, another place another night, who are traveling on the road and have to fly a lot. I mean, that's like wide open to interpretation.
Yeah, right. And they don't offer any sort of focusing of that phrase as well. Here's what we specifically mean. Okay, all right.
Not really.
Well, again, this harkens back to where we began, which was what here are the guidelines for getting your booster shot. But really, people have been getting their booster shots for a few weeks now, right?
Yeah.
I mean, just as sort of an ad hoc kind of, you've been boosterized, right?
Yeah.
Yeah, exactly.
And then here's another important thing for the J&J, people that got J&J, so it was supposed to be one and done.
Mm-hmm.
Well, apparently you need a booster. After 2 months for anybody over 18 years old. So I just saw somebody actually in clinic who'd been immunized from J&J and was symptomatic.
So you get booster for the J&J. You have to get a booster after 2 months.
You have to get a booster, yeah.
That still seems like that's not a booster. That's still your initial inoculation. It almost seems like. I mean, is that?
Yeah, and so that's the other problem is terminology gets used in different ways by different people.
Okay.
Remember, we called it third jab, and I thought boosters were going to be a fourth jab that came around somewhere around the beginning of the year. But no, boosters are now also commonly called third jabs.
Really?
So should this change the way we think about the J&J vaccine initially then?
Oh, totally.
Yeah.
Yeah. And so which boosters can you pick? Because most of us in this room, I think, are Team Moderna, right?
Yep.
Yeah. Okay, you can pick any of them. So
I don't want the J&J.
for reasons that we'll talk about. So boosters can, and it's up to the patient's choice, actually, can be, unless they're allergic to something, can be either Pfizer, Moderna, or J&J. So if you have a J&J shot and you don't like what I'm going to say about J&J, at least some of what they found in the studies, then you can switch over really easily to Moderna or Pfizer. So the special note, though, Moderna boosters are going to be a half dose compared to the initial dosing series.
All right.
Okay.
So So you don't just, first off, just if you're going in for you don't just go in for another jab. You're going in specifically for a booster shot because that's
Right.
going to be a different dose.
Okay, it's going to be a different dose for the Moderna, and hopefully that'll make the side effect profile, or what I call the good immune response, a little bit easier to live with. But the other thing is, so I asked yesterday, does public health have the half-dose doses yet of Moderna? And the answer, not officially, is no.
Well, yeah,
So
but
nobody has seen them yet. So the thought is they're not in the county, but it's possible they snuck in last night.
is it also possible that you just take half of an initial dose and use that? I mean,
I don't know.
are there medical reasons to not do that?
I think there might be medical reasons
Okay.
to not do that.
Okay.
So,
Well, I know some people who got third doses of Moderna, and it was the full dose. It wasn't a half dose.
right.
Does that make a difference?
Not in a bad way. So they probably have more robust responses, but the data that I'm going to talk about looks at Moderna as the Moderna booster as a full dose.
Okay.
Okay. So, but it's, the plan is to have it be a half dose, although I haven't seen that, and that's not really what's happening in the real world yet.
Okay. Okay.
yet. So who are they defining as high risk? So this is where they get all these specific diagnoses and then they throw it wide open. So anybody with a cancer diagnosis. So that means if you had like a little basal cell taken off of your ear, yeah, or if you've got more serious cancer. Anybody with chronic kidney disease. Excuse me, and I don't really know. I think there's a lot of people with chronic kidney disease up here who don't know they have it. Their doctors might know, but not necessarily. Chronic liver disease, so people with hepatitis C, people with alcoholic liver disease, people with chronic hepatitis B, people with, fatty liver. And again, a lot of those people don't really know they have it. Anybody with chronic lung disease, so that would be like COPD, that would be asthma, that could be emphysema. Anybody with dementia, hang on, somebody texted me right over my notes. Anybody with dementia, anybody with type 1 or type 2 diabetes. So a lot of people with type 2 diabetes are not really even diagnosed yet. So there's kind of an unknown population. Anybody with Down syndrome.
I'm just curious. Do you have any insight? How is that? Is Down syndrome a high risk scenario for?
They just seem to die.
They
don't
just
really
get it
know.
worse.
They don't
huh?
know the
They have
mechanism.
Wow.
It might be that they get sicker before somebody notices. It
Okay.
kind of depends on where somebody's ability to communicate is.
Right. Okay. Okay.
Anybody with heart disease, like congestive heart failure, high blood pressure, or coronary artery disease. There's a lot of people with high blood pressure in this county who don't know they have it. Anybody with HIV, a certain number of people up here have HIV and don't know they have it. Weakened immune system. See, that's kind of vague.
Yeah, right, because that applies to a lot of these conditions already, right? A weakened immune system.
But people think that if they take antibiotics, it'll decrease their immune system's ability to work. That's not really true.
I mean,
Excuse me.
almost anybody living in real poverty probably has
Somebody who
decreased
lives
immunity.
behind Safeway and has to live in the rain, sure. Somebody who's not eating very well, somebody with alcoholism, somebody who lives in a food desert and doesn't have money to buy fruits and vegetables, sure. People with mental health issues like schizophrenia, depression, and mood disorders. So does that include seasonal affect disorder? I mean, a lot of us get it when it rains. So that one, I think it was brand new. They just dropped that one into this list. And
Wow.
I think it's gonna. You see how they're
Yeah.
being specific but general.
Yeah.
General.
Yeah.
Being overweight or obese. There's a lot of people up here that have that issue. People who are pregnant, although there's still some resistance to that in the pregnant population up here. Anybody with sickle cell disease or thalassemia, not very common up here. Although white people do get sickle cell
What's
disease.
thalassemia?
It's an abnormal, it's a genetically caused abnormal function of red blood cells.
Okay.
So smoking, either current or former, that's like a lot of the county. Transplant recipient, now that's pretty clear. And they're talking about solid organs, mostly, not necessarily somebody maybe got skin in a burn or something.
Okay. Okay.
Anybody with a history of stroke. So that's pretty common up here. Anybody with substance use disorders, pretty common up here. Anybody with tuberculosis, not so common up here, but it used to be. In this one too, and I think this one's thoughtful, it just got put in, being in a household with a medically fragile child. I think you could extend that to maybe you could talk somebody who was immunizing into it if you were living in a household with a fragile elder too. So,
And you could also, I mean, even just with a newborn, right?
right, you could argue that.
So, I mean, you could technically argue, you could take this and the scope of this list and say this applies to, you're almost the exception if something here doesn't apply to you.
Yeah. It's almost like you have to be perfectly healthy and
Right.
living around perfectly
Like
healthy
Superman,
people.
I don't need a vaccination.
It's kind of interesting. So which booster is best? And so these data come from a preprint, not peer-reviewed multi-center study in the United States.
Okay.
Okay. And they looked at about 154 people who had received primary series of either Moderna, Pfizer, or J&J. And each person in that study was randomized to either being immunized in a booster situation with a full dose Moderna, so not a half dose, full dose Pfizer or J&J. So they had people that had been immunized with Moderna who got randomized to J&J.
Okay.
Okay. And they got people that got immunized with full dose Moderna immunized in a booster way with full dose Moderna. So, and then Pfizer. So each person was boosted and they watched them for 12 weeks. And so this was cool about this study in that they had a wide variety of ages. So they had kind of an equal balance between people above 55 and people younger than 55. But these are all adults, so 18 and over. And they looked specifically at how the IgG antibodies bonded to the spike protein, okay, part of the virus. So they took the people's blood. It's not like they gave them COVID and looked at in vitro illness. They looked or in vivo illness. They looked in vitro illness. So they took the people's blood. They isolated the part that has the IgG antibodies in it, and they threw some spike protein in it to see what the response was. And the take-home message was the safety data, because they looked at safety data and all those things that we talk about as being side effects of the vaccine, which is really a good immune response. They looked at that. They were all comparable. Okay. Moderna, a touch more, but remember it's full dose Moderna. Okay. And then they looked at what was the most effective. So J&J was less effective compared to the messenger RNA vaccines. And Moderna and Pfizer, the messenger RNA vaccines, were super comparable, but Moderna had the slight edge in both the ability to protect in the initial series and the ability to protect in the booster.
Okay.
So it's, again, important to know that that's full dose Moderna. And so I think what they're doing with the half dose Moderna is trying to make it more acceptable to people.
You think it's just a PR move like that? Like
I think
it's
there's
not
some
as
data
bad?
behind it. I don't think it's solely a PR move, but the other thing that they could do by splitting the doses is make more available for other countries too. And I think the United States is definitely under pressure for that.
But there are no studies, peer reviewed or not, are there studies peer reviewed or not that you know of in which they examine just like this one but with half doses?
No.
Yeah. Okay.
They're probably ongoing right now.
Yeah.
So time will tell, I guess.
All right. So what's this all mean then for us Del Norders here who have been vaccinated and it's time to start thinking about that? I mean, are we free to just go in someplace and ask for a third dose?
Yeah.
Should we wait for that half dose booster? I mean, it sounds like you're saying here are all the guidelines. Here's what's
Right.
going on. But really we're left to our own devices. That's what it sounds like to me. I don't know if I'm hearing you wrong. Or reading the situation wrong.
No, I don't think you're left to your own devices. I think that if you go in to see your primary care person and ask them this question, and I'm having more and more visits that are kind of bringing these questions up, then you should be able to get data-driven answers, I guess, my hope. Although I have to say there's a lot of providers who kind of glaze over when you start talking about COVID, so they might not be as thoroughly familiar with these data as they should be. But, there's some of us who are kind of geekily obsessed. So, it depends on where your provider is. And you can always ask if your provider doesn't really know. You can ask your provider to go into the medical library that they have access to and look things up. Or you can ask to maybe get an appointment with a provider who's more up to date about it. But I think most providers are right on. Certainly the nurses. Let me tell you, go team nurses. I mean, because they know all of this. And, they're willing to answer questions, and I think they do it in a really responsible way. But somewhere in the clinic that you call medical home, there should be a way to get that information. And it might mean a telephone appointment. That's not unreasonable, or even coming into the clinic if you happen to be there for another reason. This should be on the list that you bring in. And then you can, and I know at United Indian Health, you can immunize people right there. So, and I'm immunizing at United Indian Health. We have the ability to immunize people who are not our patients. So I did that yesterday where the wife was a UHS patient, and she came in with her husband who was not, and I knew that they were immunized kind of in tandem. They're kind of that couple that does everything together, and I immunized him, no problem, although he was a patient in another clinic.
Okay.
So they're like falling all over themselves. All those annoying rules that they used to have, that you can't do this because of this little rule.
Oh, sure, yeah,
thing,
yeah.
That make us all crazy about medicine. I don't like those either, but those seem to have disappeared in this circumstance.
Like what kinds of, rules, like you can't treat a patient who isn't a UIHS patient, that sort of rule?
Right,
Yeah.
or a rule that, like at Open Door, like 10 years ago, you could only address like 1 or 2 complaints. And so if you were a chronic pain, patient, pretty much you could only talk about getting your meds refilled. And you couldn't talk about your hypertension, or you couldn't talk about...
max out? Sorry, you've used up your medical credit here?
Yeah.
That was how it used to be? Wow.
Yeah.
Wow.
So I don't think they do that anymore because it wasn't really a good strategy.
Yeah, exactly.
But so those little annoying rules, they disappear now in this particular circumstance, which is super good.
So, Lynn, I would really like to go back to the J&J thing because I want to make sure that I heard what I thought I heard you say.
Okay.
That the J&J vaccine efficacy was already waning at 2 weeks.
2 months.
2 months. Oh, I'm sorry. Okay.
Yeah, sorry.
But 2 months. I mean,
That's still shorter,
isn't,
yeah.
I mean, isn't that?
It was never that great to begin with, and there's a lot of people who got J&J because it was one and done.
Yeah.
And they have no idea they have to get a booster,
Oh, my God.
or they have to. They have no idea it's advised that they
But-
get a booster.
But even like, okay, so if you got the J&J, say back in, May, it's past time for you to have that booster, right?
Totally, and they're not saying it outright, but they're kind of, mumbling it that if you got J&J, it's been greater than 2 months, then you should get a messenger RNA vaccine.
Well,
Wow.
J&J had never done a vaccine before, if I remember correctly,
Right.
and we're given $100 million in government funding to do this for a vaccine that's already waning at 2 months.
Yeah, but I wouldn't look at it that way. They got money from the government to give it their best shot. So 164. Last time we talked about vaccine development, there were 164 contenders in the United States, and we're talking about 3.
Okay.
So my guess is there's actually been government money given to ones
A lot of them,
that
right.
outright failed.
Oh, yeah,
or
sure.
remember we talked about Sputnik, which is the name of the vaccine in
I was going to
Russia?
ask about that. I wanted to know if you knew anything about Sputnik.
Turned out to be a super dog. I mean,
Really?
it really wasn't. It's not protecting people. Also, doesn't have longevity. That's
my
the whole
God.
problem with the medical interface with the coronavirus. Is protection, longevity is durability is a huge big deal. And then Sinovac that China threw out like super early, and they also kind of immunized their way through, Southeast Asia and South America. That's kind of a dog too. That's how we got Delta, because it didn't really protect, and the viral amount of viral reservoir in there allowed for mutations to be happening at a higher rate. And then we got Delta. So
I'll be damned.
the messenger RNA vaccines are rock stars
Wow.
compared to the huge number of vaccines that are around in the rest of the world.
My guess is very few people who had J&J have any idea.
Right. That is the take-home message
Right.
of this particular talk. Is if you got J&J and you thought you were one and done, you're wrong. You need a booster, and kind of the best booster to get is
Moderna or one of the Moderna or
one of the
Pfizer.
messenger. The efficacy and durability of Moderna compared to Pfizer is Moderna is still a little significantly better, but it's kind of a close race there. Moderna is definitely better against Delta. So. Yeah, a lot of money got given to drug companies to make these drugs, and there are way more failures than you're suggesting. J&J is actually kind of a success, but not as good a success.
Yeah, I
Wow.
guess it was really the first time that I had heard that basically after 2 months, J&J is already at a point where you need more.
Right.
Yeah, I didn't know
Right.
that either.
I had never heard that before.
It'll be interesting to see as we collect data on the people who got initial J&J and then boost with J&J, what kind of durability they have with that. And then you never know that J&J might end up being the most effective one against Mu, because Mu has some resistance to messenger RNA vaccine immune response. So the tools that we use best now might not be the tools we use best in a year. So that's something to think about too.
So if you're thinking it's time for a booster shot for you, the place to begin is just to talk to somebody, talk to your physician, talk to your nurse, go
Right,
into your
and if
clinic of
you're-
choice,
And if your physician just kind of looks at you and says, I don't know.
get a new physician.
No.
I know that's much easier said than done here, but yeah.
Well, that's going to change too.
What do you-
Sports fans. There's
What are you
news.
talking about? What?
There's something on the horizon. I'm not ready for prime time yet.
What?
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 Leave you dangling.
Oh my God!
This isn't prime time. That's like
Yeah. This is
We're a fascist killing
infomercial.
machine.
Yeah, this
late
machine
morning
kills-
drive.
All right. So okay.
So anyway, then you could, if you wanted to, you could call United Indian Health. They are immunizing people who are not UHS clients, and the nurses there are rock stars, and they'll let you know, about the data, and they'll talk to you. They do not have half dose Moderna yet, as of yesterday. So,
But you could walk in and talk yourself into a full dose. That's what I'm trying to understand here is what's going to happen, because it seems like these rules are just sort of all over the place, and it
I
just may be
know.
where my head is this morning.
Right.
But it really does seem like everything's on the table.
yeah, pretty much.
Okay. So
Right.
if I had a rapport with my primary care physician, I could walk in and I could say, hey, look, I would like to get a booster shot. Can you just give me a third Moderna? And they would go, yeah, sure.
Yeah.
Maybe. They would go, yeah, sure.
Yeah,
Okay.
I think so your healthcare provider is the community clinic, right? Down our community? Yes, I think they would.
Okay. Do you
Yeah.
know if they're still doing the vaccinations over here at on Norris behind the
Yes,
the
they are.
rancheria?
And she kind of sits out there and with nobody, and
just
it's
waits, yeah.
super frustrating for her.
So if you're in our neck of the woods, Elk Valley, Birch Tract over here by the Elk Valley Rancheria, at their basically it's their preschool back on Norris, back behind the tribal offices off of Humboldt, off of Howland Hill. They're just sitting there waiting to vaccinate all day. And I
Yeah,
know
you
that-
could get it done in 10 minutes. So Shami is the nurse that's working that, and she gives really great shots, and she is a COVID warrior princess.
you,
Shots in arms, baby.
Oliver, you were vaccinated there.
Yeah, I was.
It's on video, actually. You can go. Anything else then, Lynn?
Yeah, there's an antidepressant now, super cheap, that looks like it has some significant COVID advantage in treating acute COVID.
Like
so
$3 grams? What are you talking about here? No, I'm just
I am actually. It's $4 for a course of therapy. They're saying right now.
So what is this again? What is this? Is it brand new medicine?
It's not, and it comes from a really cool thing. So there was an international effort to look at drugs that were already understood as being safe,
Okay.
to see if they, and this is very smart. So in the way they set this up, I'll talk about it more because I just kind of got this information this morning. But this organization I think it's called Together. It's got the rest of the name, but I'm not remembering it. So they got about 8 drugs together. Ivermectin's one of them. Hydroxychloroquine is one of them. And their study went until they proved that it was either meeting the benchmarks as helpful or failing to meet those benchmarks, and kind of tossed in the also ran pile. And so Luvox actually has some exciting data.
Luvox. Now, what is Luvox originally intended to do?
It's an antidepressant.
Okay.
It's a selective serotonin reuptake inhibitor.
Okay, and then what are they finding it does in addition
I
to
was
that?
going to talk about that next week.
Oh, okay. I thought you were talking about kids' vaccinations next week.
No, because this
What
is
it
way
says
more,
at the end at the bottom.
Well,
Oh, but you just
sorry,
found out.
kids.
Okay, so this
Yeah,
is
this is-
sorry, kids.
This is breaking
And
news.
there's a big development regarding health care.
I can talk about both.
That'll be part of
kids.
next week's program, maybe.
Right. It's like breaking news, but the way they found it out is kind of exciting. And then what they found out about some other drugs that are kind of touted as helpful aren't.
Okay, excellent. That's cool. I like that.
Data-driven.
All right,
Okay.
and so then subsequently we'll talk about
Yeah, I'm not going to
children.
forget the kids.
Don't forget the kids.
Yeah.
They are
I'm not
the
gonna forget
future.
the kids. Yeah, they're not really getting immunized in the numbers that you would hope.
Well, yeah, because they're not getting sick in the numbers that would require them, right? I mean, has that changed? I don't want to get into something if it's a bigger thing, but I know that kids with Delta there were more kids getting sick with Delta than with the whatever the first one was called.
Yeah.
Right, the strain.
Yeah. But yeah, they get sick.
Yeah, okay.
The kids are able to go sit in the waiting room with Cocaine Bear.
What?
Don't bring Cocaine Bear into Health Matters. That's not Health Matters canon.
Oh, you're right.
Okay. Lynn Szabo, thank you so very much. So next week, talking about drugs that can be used in different ways now as we study existing drugs.
Known to be safe.
Known to be safe.
Old familiar favorites. How do we use them to fight COVID?
Okay. All right. Lynn Szabo, PA at large in our community and Health Matters. Thank you so very much.
Thank you.
All right. We'll see you next week.
The truth is under attack almost every night by local underground ghouls, goblins, and spooky green witches who will terrorize you to get their way and hinder the facts. The only defense stronger than my tinfoil helmet is to flop under the rays of KFUG Community News. Every day at noon, listen in the safety of your own home from every couch worldwide. Witness just a drop the unbelievable on 101.1 FM and online at KFUG Radio.